The topic for discussion today is shock. Shock is actually potentially life-threatening situation, usually characterized by impaired perfusion and thus impaired cellular metabolism, and it can lead to the associated pathophysiological reactions associated with the impaired perfusion and impaired cellular reaction. Usually there are many types of shocks, and the most commonly encountered shock is hypovolemic shock. Usually there is an axiom that is like hemorrhage means shock and shock means hemorrhage. So hypovolemic shock is such one of the commonest types of shock. Coming to a shock, it is a condition where circulation fails to meet the nutritional needs of the cells, and at the same time it fails to remove the metabolic waste products. Because of this hypoperfusion to the cells there, what happens is there will be increased anaerobic metabolism there, increased anaerobic respiration, leading to lactic acid, more amount of lactic acid within the cells, and in turn it causes cellular impaired cellular metabolism, and it further results in death of the cell. This is characterized by, as we have already seen, it is characterized by diminished tissue perfusion and damaged cellular metabolism. The results from inadequate blood flow or oxygen delivery. What happens when there is decreased perfusion to the cells? Oxygen carrying capacity of when there is decreased perfusion, the oxygen that is been transferred to the cell also will be diminished, and hence the cellular metabolism is thus damaged there. So shock usually results from inadequate blood flow or oxygen delivery to the particular cells. In short, more oxygen consumption than oxygen supply. In shock, what happens is the consumption and supply imbalance happens. The amount of oxygen supplied to the cells is not enough for the regular metabolism of the cell. The diminished blood flow to the vital organs leads to shock. What is the actual pathophysiology of shock? Whenever there is inadequate perfusion, cells undergo hypoxia, and this further results in deficiency of energy within the cells, that is impaired cellular metabolism. With this impaired cellular metabolism, what happens is the lactic acid, which is because of the anaerobic metabolism that is happening there, where oxygen is not present, amount of oxygen that is being supplied is less. What happens is the cell adapts to anaerobic mechanisms, that is anaerobic metabolism. With this anaerobic metabolism, what happens? The lactic acid accumulates and there will be fall in the pH, and acidic environment is created within the cell. This results in metabolic acidosis. Metabolic acidosis in turn has an effect on blood vessels, where it leads to vasoconstriction. When vasoconstriction is present, there will be failure of these precapillary sphincters, resulting in peripheral pooling of blood. Along with this peripheral pooling of blood, because of this metabolic acidosis, the cell membrane function is also lost, and there will be failure of sodium pump. What happens is sodium will be present within the cell, and the potassium flees off, that is potassium moves away from the cell. So there will be sodium, because of this failure of sodium pump, sodium retention within the cells happen. With this, what happens is the intracellular lysosomes release certain digestive enzymes, which will further enhance this efflux of potassium and influx of sodium and water. This particular mechanism completely is called as sick cell mechanism. What it is? It is sick cell metabolism. So with this, what happens is the efflux of potassium and influx of sodium and water, the toxic substances enter the circulation, resulting in toxemia within the blood, when it further causes capillary endothelium damage, resulting in destruction, dysfunction and cell death. So this is how the actual pathophysiology of shock happens. There are various types of shocks, and as we already have seen, hypovolemic shock or hematogenic type of shock is the most common among them. So what are the various other types of shocks? These other types of shocks include traumatic shock, vasovagal shock, psychogenic shock, we have cardiogenic shock, septic shock, and other miscellaneous shocks like anaphylactic shock and insulin shock. Among these, when we are talking about hypovolemic shock, which is one of the most commonest types of shock, it is usually caused because of acute loss of blood, either a chronic loss of blood, and most commonly it is due to sudden loss of blood. There will be loss of intravascular volume because intravascular volume is decreased in this, and thus perfusion of the cells is also diminished, resulting in shock. This will again causes other features of this hypovolemic shock include decreased filling pressure of the heart, tachycardia, decreased systemic arterial pressure, and increased vascular resistance. It is also characterized by, as we saw, tachycardia, and there will be low blood pressure, low cardiac output, and vasoconstriction. Here what happens is, whenever in case of hypovolemic shock, we have particular mechanism called as Frank-Starling mechanism. In this Frank-Starling mechanism, the cardiac output, which is the volume of the cardiac output, increases with the increase in the filling of the cardiac, when there is increase in the cardiac filling, there will also automatically increase in the cardiac output. This is called as Frank-Starling mechanism, which we usually encounter in case of hypovolemic shock. So what are the compensatory mechanisms that happen during this hypovolemic shock? As we have already seen, the clinical features are decreased blood pressure, decreased cardiac output. So to compensate the decreased blood pressure, body has this adrenergic discharge can be seen. Hyperventilation. We can see patient respires more than what is needed. He or she breathes more vigorously, resulting in hyperventilation. And we also see effect of vasoactive hormones can be seen. Hyperventilation is again a compensatory mechanism for our metabolic acidosis, which we have seen because of decreased perfusion. Because of hypoxia, we have seen metabolic acidosis. So to decrease that metabolic acidosis, in turn there will be compensatory mechanism with hyperventilation, where the carbon dioxide which has been inhaled will be diminished. So it will result in alkalosis, thus compensating this metabolic acidosis. Then effect of vasoactive hormones, and finally it can lead to collapse, and interstitial fluid resorption can also be seen as compensatory mechanisms. So we have various clinical features and this based upon the severity and amount of blood loss. Hypovolemic shock is further classified into three types. One is mild shock, moderate shock, and severe shock. In mild shock, what happens is, when there is less than 20% of blood loss, then patient enters into a situation called as mild shock. Here patient usually have sweating, fingers and extremities become cold and clammy. And if at this stage, if patient is treated properly with resuscitation, then he or she can come back to normal stage without much effort. In case of moderate shock, when the blood loss is usually more than 20, it is in between 20 to 40%, then patient will actually enter into moderate shock. Here what happens is, there will be decreased urinary output, and BP will also be decreased, but pulse rate is usually normal in this condition, where it will be almost less than 100. In case if the bleeding is, or if the blood loss is greater than 40%, then patients can enter into severe shock, where patient can ultimately lead to collapse. There will be less cardiac output, decreased BP, decreased urinary output, and ultimately they can lead into collapse or sometimes death also. So this is about the various clinical features of shock. Now coming to clinical monitoring, how do we actually monitor the patient who is under shock? First is blood pressure. So in case of blood pressure, both diastolic blood pressure and systolic blood pressure has to be checked for. As we have seen in the clinical features, the BP is usually lowered in the case of shock. When we are checking for systolic blood pressure, in systolic blood pressure, we can identify the stroke volume, and in diastolic blood pressure, vasoconstriction can be evaluated. When we are checking for respiration, patient usually is hyperventilated and urinary output is decreased. In case of central venous pressure, usually in hypovolemic shock, central and other types of shocks, central venous pressure is usually decreased. However, in case of neurogenic shock and traumatogenic shock, CVP, that is the central venous pressure, is usually normal. When coming to ECG, in case of severe shocks, then we can see ECG abnormalities. ST-T wave depression, segment depression can be seen, which is almost similar to that of MI in case of myocardial infarction. How this ST-T wave segments or STT segments depression is seen, similar depression can be seen in case of severe shock in case of ECG. And one catheter called as Swan-Ganz catheter. This Swan-Ganz catheter will help us in identifying the cardiovascular flow. It will also help us to know various blood gases that are present within the venous blood supply, and also it will be useful in measuring the filling pressure of heart. That means this Swan-Ganz catheter will be useful in measuring these above three conditions. So this is how we actually monitor a patient who we suspect or in whom we suspect shock. Now coming to management. The primary management in case of shock is resuscitation. In this, establish airway, ventilation and oxygen. ABC, airway, breathing and circulation has to be identified in these cases, and we have to establish proper airway, proper ventilation and oxygenation. For this, we also have a method called lowering of head with head support. You have to lower the head with head support, and in severe cases where patient is not able to breathe properly, intratracheal intubation or mechanical ventilation has to be delivered to the patient. Now, as we have seen, hypovolemic shock is because of acute loss of blood. This can be because of an external injury or an internal injury. If at all we have seen an external or internal injury, always try to control bleeding immediately. For this, Trendelenburg position is useful. In this case, what happens is legs are elevated with head in the lowered position. With this Trendelenburg position, the peripheral pooling of blood is stopped. I mean, we are preventing the peripheral pooling of blood and helping for venous return to heart and also to a cerebral perfusion. And compression bandage, whenever there is more amount of blood loss from any extremity or any superficial surfaces, compression with a bandage will be helpful in preventing excessive blood loss. Other hemostatic measures, either the local hemostatic or systemic hemostatic measures. Local hemostatics like styptics like Oxycell, Surgicel, local suturing. If there is bleeding from bone wax, etc. can be used. And in severe cases where there is internal bleeding, if needed, surgery has to be done to control this bleeding. As we have seen in hypovolemic shock, what happens? The intravascular volume is decreased. So, to reload this intravascular volume, extracellular fluid replacement will be helpful. This extracellular fluid replacement, whenever we see a patient in hypovolemic shock, start immediately. Simultaneously measure the central venous pressure so that we can know how much amount of fluid has to be replaced within the body. Administer Ringer's lactate or acetate or normal saline with 1 or 2 ampules of sodium bicarbonate. Rapid replacement of fresh blood after control of hemorrhage will be helpful in bringing back the blood nutrients in the body. Now coming to drugs, there are various drugs or medication that will be helpful in bringing back the patient from hypovolemic shock. These include various sedatives like morphine, barbiturates and pethidine. However, make sure when there is a cerebrovascular injury, avoid morphine in those cases. Chronotropic agents such as atropine, isoproterenol can be used. Inotropic agents like dopamine and dobutamine can be used. Various vasoconstrictors like phenylephrine and metaraminol can be used. Vasodilators like nitroglycerin and nitroprusside. Various beta blockers like propranolol and various diuretics can be used in helping the patients in elevating the shock. Now coming to another type of shock called as traumatic shock. In this traumatic shock is also a type of hypovolemic shock. Usually here what happens is there will be loss of blood. Other thing is when there is trauma activates, whenever there is a trauma, this trauma can activate the coagulation cascade there, and this will release in the process of this coagulation. In case of this traumatogenic shock, what happens is within the after the coagulation cascade completes, there will be release of microthrombi, and these microthrombi can cause occlusion of the microvasculature. What happens when the microvasculature is occluded? Definitely the peripheral tissues which have to be supplied by this microvasculature will be compromised in perfusion, and there will be hypoperfusion to this peripheral tissues. In these cases what happens, there will also be increased resistance of pulmonary vasculature. There will be decreased vascular volume due to escape of the plasma as capillary permeability increases in case of traumatogenic shock. What are the clinical features of this traumatogenic traumatic shock is? In internal or external injuries or major fractures and burns, we can see this. there can be pulmonary and peripheral edema. Why will there be pulmonary and peripheral edema? Because what happens in traumatogenic shock, when the capillaries which have been occluded will try to push this blood into the adjacent structures. In this process of pushing the blood, the vasculature, the wall of the vasculature, what happens, gets thin or get breached, resulting in fluid escape from the vasculature, resulting in peripheral edema or pulmonary edema. In case of chest injury, where there is contusion injury to the heart directly, there can be damage to respiratory system, thus further leading to hypoxia. How do we manage this? Similar procedures like how we manage hypovolemic shock. It includes resuscitation, bring back, again establish airway circulation and breathing to the patient. Hemostasis, very important, especially in case of external injuries or any fractures, and fluid replacement to bring back the volume of the vascular volume. We have to go for fluid replacement. Now coming to cardiogenic shock. And this cardiogenic shock, it is due to dysfunction of one ventricle or another. It can be usually because if there is more, if the one ventricle is fibrosed greater than for 50%, in those cases it results in cardiogenic shock. In this cardiogenic shock, what happens is it can lead to dysfunction of left ventricle or dysfunction of right ventricle. In dysfunction of left ventricle, what happens is the pumping capacity of the left ventricle diminishes because of this fibrosis. Because of the fibrosis or because of the complete dysfunction of the ventricle to pump blood. In this case, there will be dysfunction of left ventricle. As the pumping capacity of left ventricle decreases, the right ventricle, which has been pushing the blood into the left ventricle, cannot pump properly, and there will be leakage of the blood or fluids into surrounding tissues, leading to pulmonary edema or peripheral edema. Cardiac compression shock. When there is a direct injury to the heart, this can lead to tension pneumothorax, diaphragmatic rupture or pericardial tamponates, and this will also result in shock, that is cardiogenic shock. So what are the various clinical features of this cardiogenic shock? Patients usually appear pale and skin becomes cold. There will be clammy, where we can feel the sweating on the hands and the extremities, on the skin, and there will be decreased urinary output. Rapid pulse with low arterial blood pressure is seen. Distended neck veins or hepatomegaly can be seen, especially in case of right ventricular dysfunction, and in case of left ventricular dysfunction, we can see bronchial rales and we can hear a third heart sound. Now coming to the management, similarly resuscitation, the primary treatment for shock, remember, is resuscitation. Clear the airway, give adequate oxygen supply. In case of pulmonary embolism, heparin injection will be helpful to lyse those microthrombi. Morphine in conditions of pain, and diuretics, especially in case of pulmonary edema. This will help in elevating this edema, removing of the edema, and thus bringing back the function of again your right ventricle. Now coming to neurogenic shock. Neurogenic shock is also one of the frequently encountered type of shock, especially in case of spinal cord injury or in cases of spinal cord anesthesia. In case of spinal anesthesia, we frequently encounter with this neurogenic shock. Also, it is caused by paraplegia or quadriplegia. The various types of this neurogenic shock includes vasovagal shock or vasogenic shock and psychogenic shock. Psychogenic shock is usually when patient enters in severe pain or a sudden shock. Because of a sudden news such as a bad news, patients undergo into psychogenic shock. When we are talking about vasovagal shock or vasogenic shock, what happens is from the periphery, that is especially the limbs or musculature from the limbs, the blood has to be supplied back into the, the venous return is not properly happening in case of vasovagal shock. Because of this decreased venous return to the heart, there will be low cardiac output and thus resulting in shock, which is also called as neurogenic shock here. Now, how the patient appears in case of neurogenic shock. Remember, in all kinds of shock, usually patient is cold and clammy, whereas in neurogenic shock, because there is no blood loss, usually the patient is warm. And again in septic shock also, you can see patient who is warm, they are well perfused and usually pink skin. However, in hypovolemic or other types of shock, what happens? Patients are usually cold, clammy and pale. Remember, this is the difference between the neurogenic shock and your other types of shock such as hypovolemic shock. Another important difference here is usually The urine output is normal in case of neurogenic shock, whereas in case of cardiogenic or in case of traumatic shock or in case of hypovolemic shock, urinary output is usually decreased. There will be rapid heart rate and low blood pressure, which has been measured in case of neurogenic shock. Management, Trendelenburg position again for bringing back the perfusion, bringing back the venous return to heart, because we have seen that vasovagal shock is usually because of pooling of blood in the large vascular areas, thus causing decreased venous return, and which will also cause low cardiac output and reflex bradycardia in these cases. In these cases, remember one important thing was, as we as a dentist or oral physicians, in case of this vasovagal shock, if patient encounters a vasovagal shock on a dental chair, do not make the patient sit erect. Always give them a Trendelenburg position. By sitting erect, what happens is there can be permanent damage, because venous pooling at the periphery is more pronounced in those cases, and by sitting erect, what happens is no returning back of this venous blood, thus causing permanent damage in those cases. So if we encounter a shock, especially a vasovagal shock on the dental chair, always give the patient a Trendelenburg position. Fluid administration, it is not very much required, but little amount of fluid administration will be helpful. And vasoconstrictor drugs, remember in all other drugs we are giving, in all other type of shocks we are actually giving initially vasoconstrictors and then vasodilators, but in case of vasovagal shocks, we are actually giving, or neurogenic shock, vasoconstrictor drugs will be of use. Now coming to septic shock. Septic shock is again one of the most common shocks that we encounter in any case, usually in case of trauma, in case of burns, or in case of any infections, GI tract infections, or infections which have been damaging any other internal organs, may sometimes, if not properly treated, or if patient is not under antibiotic prophylaxis, then this can lead to septic shock. Again, the septic shock is of two types, which is based upon the organisms that is causing this. It can be because of gram-positive or gram-negative. Often gram-negative septicemia is more encountered, and this is the most dangerous type when compared to a gram-positive septicemia. In severe septicemia, what happens? There will be peritonitis, meningitis and cholangitis, and of course we know meningitis can be potentially life-threatening. In case of this septic shock, there will be increased cardiac output in early stages, and later there will be decreased vascular resistance leading to hypovolemia. The toxins that have been released by these organisms can cause cardiac function damage. These toxins can be either exotoxins or endotoxins, and gram-positive bacteria usually releases exotoxins. These are the steps how sepsis progresses, where it can, after sepsis, there can be severe sepsis, and this can lead into septic shock, which is potentially fatal again. The most common organisms that are usually causing septic shock include Klebsiella, Proteus, Pseudomonas, bacteroids, E. coli are some of the most common organisms that are frequently encountered in case of septic shock. Now coming to gram-positive sepsis. In this gram-positive sepsis, what happens is, more than bacteremia, the exotoxins are present in case of this gram-positive sepsis. Here, once a patient will have exotoxins released, this can lead to septicemia within the whole body. Patient appears warm, they can be sweaty, and in case of gram-negative sepsis, what happens is there will be some severe infection, especially the GI tract infection. Sometimes what happens, in some patients there will be tracheostomy or some medical emergency will be used, and in the tubings or in the material on the catheters, what happens is there will be some amount of bacteria which is already present there, which can enter into the body releasing endotoxins, and this can lead to gram-negative sepsis. Now coming to the clinical features, because of the septicemia, patients usually have, or bacteremia, patients usually have chills, increased temperature. And the two types of shocks again here, one is early warm shock or late cold shock. This early warm shock is late cold shock is present. This early warm shock is also called as hyperdynamic shock, and this late cold shock is called as hypodynamic shock. When you're talking about this early shock is where we have anaerobic metabolism usually because and there will be secretion of lactic acidosis, and in case of late cold shock usually called as hypodynamic shock, where this usually is encountered in case of severe sepsis and there will be generalized capillary leakage resulting in severe hypovolemia in case of late cold shock. Now coming to management, treatment is of this infection is usually by antibiotics or surgical debridement. Whenever we see an open wound and it is been necrotized with pus, always remember clear of the pus and clear of the infection there, I mean the inflammatory process that has been happening there. This will actually promote healing and reduce this sepsis. And finally, when there is no sepsis, obviously septic shock can be prevented in those cases. Fluid replacement will also be helpful but not much required like in hypovolemic shock. And then steroids, especially methylprednisolone or dexamethasone, can be useful. And vasoactive drugs like isoproterenol and metaraminol will be useful in case of this septic shock. Now coming to the conclusion, I mean when we are talking about shock, you have to actually identify patient at high risk. Whenever patients are coming to a dental office or to a physician, always try by observing whether patient has the symptoms, the whole symptoms or risk factors that patient might enter into shock. Control or eliminate that risk factor. Sometimes simple anxiety can also be a risk factor for shock. I mean anxiety is definitely not simple, but then when patient has that anxiety or fear towards a treatment or dental treatment, even then also patient can undergo into shock, especially psychogenic shocks or vasovagal shocks, where it can be potentially life-threatening also. So proper counseling with the patient, eliminating that fear, eliminating that anxiety can be helpful. And other things such as bleeding and whenever there are any external injuries can be a risk factor for hypovolemic shock. In those cases also control or eliminate the factor. And in case of neurogenic shock, when we are talking, the spinal cord injury or spinal cord anesthesia can itself sometimes lead into this neurogenic shock. So prevent such conditions where the proper treatment sometimes can lead into shock. So prevent such or eliminate such risk factors. Always do not forget ABC, that is airway, breathing and circulation. Always maintain the resuscitation to a patient whoever is in shock, and implement measures to enhance the tissue perfusion and to correct the acid-base imbalance. And early intervention, prompt treatment, prompt recognition and treatment and of that condition will be helpful in saving patients who from shock and bringing back them to better outcome and bringing back them to normal situation. So this is all about shock. Thank you.